Peterson Wachira. He is the chairman, Kenya Union of Clinical Officers. And the conversation that we want to have today is, talk about SHA, the demos, and basically the Kenyan state of health, or rather the health of the state of Kenya's health, basically. So Peterson Wachira, a very good morning to you and welcome to Radio Generation.
Good morning.
Good morning.
And my apologies, I was late.
Yes.
Because of a meeting I was in.
Yes.
I'm not usually late.
It's okay.
We have a very huge conference room here.
Yes.
Next time, bring the meeting here.
I didn't know. Probably we can think of that.
Yes, but karibu sana.
But I was listening to you
Yes.
as I came.
Mm-hmm.
And you know much about health and about clinical officers?
Actually, I have a question because
Yes.
I would like to understand what the role of a clinical officer is. And are they any different from a doctor, even in terms of the training, in terms of their responsibilities and their abilities as well?
Okay. Very well. So as you have said, my name is Peterson Wachira. I am the National Chair for Kenya Union of Clinical Officers. I also sit as the chair of the Health Union Caucus. That is when the unions in the health sector come together. So we have many different professionals within the health sector.
Right.
But we have those that we call clinicians. Clinicians are the ones who diagnose you and treat you.
Okay.
And that is usually clinical officers and the medical officers and the dentists. So clinical officers, our scope is relatively similar to the medical officers. Because, when you say doctors, the doctors in Kenya encompasses 3 different cadres.
Okay.
We have the pharmacists, we have the dentists, we have the medical officers. So clinical officers, our scope is almost similar to the medical officers, albeit on the surgical side.
All right.
Where now they are able to do more into the invasive surgeries than we do.
Okay.
But when it comes to training, our training has a difference at degree level of 1 year.
Okay.
So we have 2 levels as basic. We have a diploma that we do for 3 years and 1 year internship. So our diploma is actually 4 years. And our degree is 5 years. 4 years in school.
All right.
1 year internship. As opposed to theirs, which is now 6 years. So the difference, as I have said, is majorly in surgeries.
Okay.
But on the other conditions, it's relatively similar. So we work as the primary clinicians. Primary clinicians means that when you come to this facility,
Yes.
we are the people who primarily see you. We are the first to see you. And then probably if you need to be admitted and followed up, that is when mostly now you'll be followed up by the medical officers.
Okay.
So in Kenya, out of 100 patients who come to hospital, only about 9 get admitted. And so that means that we see about 91% of Kenyans. We actually see 100%.
Yes.
Then we admit 9% and they are followed up by the medical officers in the wards.
So in terms of training, you all do a course called medicine.
Yes, ours is called clinical medicine.
Okay.
Theirs is called, ours is clinical medicine and surgery. Theirs is medicine and surgery. But the books are the same. I think it's only the title called.
So you all do anatomy.
Anatomy is anatomy.
Yeah.
Biochemistry is biochemistry. The books are the same.
Yes.
It's only that the time duration. Ours is a crash program. Because, how it came up, it is very interesting. The white man did not believe that an African can grasp medicine. So if they did some on job and you seemed to understand medicine,
Yes.
then they called you a clinical officer because you cannot be a doctor.
So it was a racist thing.
Kind of, and you would see the blacks. It started in St. George Hospital,
Yes.
now Kenyatta.
Yes.
In 1928, we have existed in Kenya since 1928. But then it evolved later to become a profession that actually the country relies on because we carry the burden of healthcare. And with the years, actually other countries have borrowed from Kenya, from WHO benchmarking. The United States, They came here. We actually sat with them. They took our curriculum. The physician associates in the US
Yes.
is a replica of clinical officers in Kenya, though we are actually much advanced than themselves because they just started the other day, and even we do much more than they do.
Yeah.
The physician associates in the UK, and now basically we are in all continents. We have identified around 78 countries where our analogs or equivalents are. Although we have 33 different titles, but we are in the process of harmonizing so that we can get one title across the board because we want to globalize the labor market for clinic officers.
Right.
And I'm happy to report that we already have a breakthrough with the UK, and now clinic officers from Kenya can actually be registered in UK as physician associates trained outside UK.
Right.
And we have several working there. We actually have a conference in August. Where we are going to Aston University, bringing the 78 countries together. Yes.
So you want to tell me that you're all called doctors?
No.
So you're not. So if I walk, because every time I walk to a hospital, of course I won't ask who is a doctor here and who is a physician and who is a sijui what. Mimi nasema tu nimekuja hapa naumwa na tumbo nisaidieni.
You see, there are 3 definitions of doctor.
Okay.
There is a doctor with a philosophy doctorate. That is the academically recognized doctor.
Yeah.
We have the honorary doctor, like the one that is given to the doctors. If you look at their act, they like patented the title to only apply to them. But then if you go to the English dictionary,
yes,
then a doctor is anybody who treats. So it depends. If because most of us out there are called doctors, though we don't like that, because when you're called doctors, we are mixed up with the others and we lose identity. We like being called clinic officers.
Okay.
But if a person calls you a doctor, they are calling you from the dictionary meaning.
Okay, you know, I'm also wondering because the nurses were also pushing to be called doctors. Na nyinyi hamtaki kuitwa doctor?
No, but you see, what is in a title? For me,
yes,
I would rather have a unique title that identifies who I am.
Yeah.
Because for so long, and before we founded this union, clinical officers were actually left in oblivion. Kenyans did not know who we are. They used to call us doctors. So whenever the government says we have sorted doctors, they think they have sorted us. But that was not the case.
Okay.
So we needed to come out and stand out as an independent cadre.
All right.
And that is what we have done. I believe by now, Kenyans know there is these people who are called clinical officers. They also know what we do. When you come to the hospital, most probably the person you'll be calling a doctor is a clinical officer. And we are very qualified. We are found across the globe. Many countries, many Western countries only came to realize that they needed this profession way later because you'll never have enough doctors.
Yes.
So you need a primary clinician who can be able to carry the load. And that is why now we have them across the board.
Now, in terms of like when a doctor, let's say Dr. Paul Mungala Mbuvi,
yes,
is a doctor, is a medical doctor.
Yes.
Alafu unaona hapo kando ya jina yake wanaeka MBCHB,
yes,
meaning that he has also done surgery, I guess. Or he's a surgeon or something of the sort. So for a clinical officer,
MBCHB is the basic.
It's the basic one.
It's a medical officer.
Okay. So now, for you clinical officers, what is the abbreviation?
The abbreviation
equivalent of MBCHB.
We write it as SIMS. So we have diploma SIMS. So it will be D SIMS, CIMS.
Okay.
We have BSc. We also have masters. Masters now, but the title we carry for diplomas, the title we write there is registered clinical officer.
Okay.
For BSc, you drop the registered. They are called clinical officer. For the masters, they are called clinical specialist. So that is the title you'll see on their badge.
Okay.
So if you happen to do a PhD, is there, first of all, is there a PhD for clinical officers?
Yeah, Mount Kenya started one.
So if I happen to do a PhD,
yes,
and I successfully
you carry the title
complete,
doctor.
so now I'll be called
In fact,
doctor.
we have several. We have so many who are called. So they're right there. Dr. So and so,
Yes.
clinical specialist.
Okay.
Yes.
Now I understand.
That's
I've
amazing.
understood.
That's
Because that
amazing.
is academic doctorate.
Oh yeah.
So, and that is why I'm asking, what's in a title? You know, other
Prestige.
than PhD,
Yeah.
everything else is honorary.
After PhD.
The only real doctor title is PhD.
Okay.
Anything when you have not attained a PhD is called an honorary doctorate. You know what honorary means?
You have been honored with that title.
We have just honored you, but you have not
Yeah.
earned it.
Yes.
Yes.
Well, in light of the KUKO's list of objections that you made to the government regarding the merger of regulatory bodies
Yes.
under the quality of care bill, how is this affecting your work as clinical officers?
Very well. There is first the question of merger
Yes.
of the regulatory bodies.
Yeah.
And then there is the second question of the quality of healthcare and patient safety bill.
Yeah.
So about the merger, in February, you remember the cabinet sitting in Kakamega made some resolutions. And the resolutions were that their parastatals are becoming a burden on the exchequer. And that there were many that were doing probably a similar job, or whatever they were doing can be done under the departments in the ministries.
Yes.
And so there was a resolution: can we merge some? Can we dissolve some? Can we declassify and defund some? So those in the health sector, they were categorized under declassify and defund. And so that a Kenyan citizen would understand what that means. It means if it was a SAGA, a state agency, then there is an obligation on the government to fund it. If you declassify, it is no longer a SAGA, then it is not obligatory for the government to fund it.
Yes.
So that is what they did, so that these bodies can use whatever they collect without being funded by the government. But then, the people behind the shadows that we usually call the cartels, they have always been pushing this narrative of merger. And the narrative of merger, the reason as to why, because anybody would think that would be a very nice thing. One center for everything and regulating everything. But that is not the objective. Because, you know, there is usually what is sold and the reality is hidden behind. So it was about dominance of the health sector. And that is what we are against. Because merger would then take us to state regulation of health workers. But that is a place we came out a long time ago. Because it was proven, there are so many papers that a state regulation is inferior to peer regulation. And that is how we all move to peer regulation. If you go to the body that registers journalists,
Yes.
who sits there? It is journalists
Yes.
who are experienced and senior. If you go to engineers, who sits there? In their councils and boards?
Engineers.
If you go to LSK,
Lawyers.
so how do they then come and tell us that for health workers, we will only maybe ask you to give us 2 representatives, and then out of 11, everybody else is from outside. So it has been shown that peer regulation is the best regulation, because people have an inherent desire to protect their field and protect their image. And so if they self-regulate, they will not allow you to do monkey business.
Yeah.
So the merger wanted to take us back to the state regulation. And you know, the demerits of that is that the moment it now becomes the state loading the regulation on us, I think what we are going to do by default, and what will happen at times, is that because people do not want to their image soiled and they have no control, people start hiding. In the medical sector, we say errors are inevitable. You know, there is a difference between negligence and errors. Errors will always happen. And we report errors. We are encouraged to report errors. It is something that is negative. I wanted to do this, but it didn't go the right way. And you report so that then they can see why and it can be corrected in future. We do that voluntarily. But if you load state regulation, where I know some of the people sitting there are politicians and they are going to probably blow it out and taint our image, do you think we are going to report these errors? We will not.
What if we can have that state regulation,
Yes,
but have the people sitting there your peers? So it can still be a state regulated body, or rather state regulatory body, but everyone sitting there everyone sitting there is someone in the field, such that we meet in the middle, literally, for lack of a better word.
that is peer regulation, and that is what is happening now.
Yes.
But what they wanted to do, and you remember in 2021, under the President Uhuru Kenyatta, and I think then it was Honorable Kagwe who was the minister, they also tried to do the same, to remove health workers from their own boards and bring in some other people from the state. And we successfully opposed that, and the bill flopped in Parliament. So I think peer regulation, because even the peer regulation we have, the bodies are still sagas. So they are state owned, but the people who are sitting there, it is a peer regulation. Okay. Though it is not only like in the Clinic Officers Council, it is not only clinic officers who sit there, they are the majority.
Okay.
But we have somebody from Consumer Federation, we have somebody representing the Saga Board, we have somebody representing AG. So we have various other people to come and check and even capacity build in some sort of the decisions. And if you look at like our dispute resolution, it's actually called what? The disciplinary committee.
Yes.
We even have a representative of the AG. We have somebody who comes from the Consumer Federation. The public is represented there. So that whenever decisions are being made, then they would ensure that this decision is objective and is legally sound. Yes.
Well, you also petitioned Parliament over discrimination, broken contracts, delays in internships, plus being locked out of SHA. Maybe you can elaborate that to us, please.
Yes. And maybe before that, please allow me also talk about the quality of healthcare.
All right.
And I want to start by saying that quality of healthcare and patient safety is what all health workers want. It's what any Kenyan wants. But what is our problem? And I must also say that I think at this time, this is the time we have the CS with the best capacity to resolve issues within the health sector.
That is Aden Duale.
Yes, I know that is unexpected, but that is the truth. Because he has been a leader in this country for a long time. He's closer to powers, and he knows politics. He can be able to play politics and because this country is highly political. And that is what we have not seen in the previous two CSs. And that is where we can see he has been able to stabilize the issue of internship. There is still some challenge with backlog, but I believe that is something that can be sorted. But at least they are being paid what they should be paid, and they didn't have to demonstrate. You remember the other time we protested for them to be posted.
Yes.
And also, so there is that. And now when we come to the quality of healthcare, there are several things that, and we have communicated with the CS. We have told the CS that we want to support because it's a good thing. But then there are few issues there that we must correct.
Such as?
Number one, there has not been a deficiency of provisions for quality healthcare. Let us start. We have a national policy for quality of healthcare and patient safety. 2022, I participated in that one. It has never been implemented. Many health workers, many health facilities do not even know it exists. We have the Kenya quality of health model. It is about the facilities. Everything that is in this bill is actually from there. So we didn't have a gap. It's only that we are trying to bring it in a legislation. But then we are putting very much weight on the health workers, but we are not putting the same on the people who are supposed to facilitate them to offer that quality.
Right.
Like if I do not give that quality service, I should be fined 50 million.
Mhm.
But then the question is, are the health workers the ones that are refusing to give Kenyans the quality service? Because that is what we took an oath to do. No. The reason as to why we do not provide quality service at times is because for you to provide quality service, you must have your diagnostics that are up to date. You must have your essential supplies, including medicines. You must have other equipments that you need. Are they there? They're not there. You must have a conducive environment. And other than that, even if you had all those with you, then you must have adequate numbers, because according to WHO,
Yes.
a clinic officer per 8 hours can only see a maximum of 35 patients. Clinical officers are seeing in excess of 100 plus patients
In 8 hours.
in 8 hours. So even if I had all those, by the time I'm doing the 50th patient, I'm fatigued. You know, fatigue at work, mental cloudiness.
Yes.
So by the time you're telling me your stories, I'm not even listening properly, and I will make a medical error. Not because I'm incompetent, but because I've been pushed. And you know, we are not machines.
So why are you seeing 100 patients in 8 hours? Is it because we do not have enough clinical officers, the government hasn't employed enough officers, or they just don't exist even in the market?
We have 32,000 registered clinic officers in this country. Only about 7,000 are working in the public sector. The others, of course, privates, locums, and what have you. According to the Ministry of Health, Staffing Norms and Standards 2014 to 2018, by the year 2018, we were supposed to have 16,000 clinic officers in the public health facilities.
Right.
We are in 2020,
5.
and we only have 7,000. As per the HRH strategy of the same ministry, by this year, for us to be able to implement UHC, we were supposed to have around 24,000 clinic officers in public facilities. We have how many? We have 7,000. So in effect, one clinic officer has to carry the load of about 3 clinic officers, because 24,000 divided by 7, 3 clinic officers.
Yes.
So you have to do 35 times 3.
Okay.
And of course there will be excess, and because patients have to be seen, and you know, now we are under the county governments, you don't see them. Some of our people have been slapped. But what I was trying to say, you cannot put the burden to provide quality on the health worker, but then you do not put on the person who is supposed to facilitate them by providing the equipment, the resources that are needed. On the same, you punish me because I didn't provide, but it is not because I didn't want to.
Is this something that is arguable in a court of law?
I don't think we need to go to a court of law.
No,
because there is a
in case of these so-called errors or mistakes, that the medical mistakes we were talking about earlier,
Yes.
and I happen to sue you because you probably made an error on treating me,
Yes.
is it something that you're able to get out of in case it gets to that, and explain, look, by the time I was seeing movie, I had seen 150 other people, so by the time he was getting to me sikuwa naona kitu?
Unfortunately, and especially if it gets to a level and the judge terms it negligence,
Yes.
then you cannot run away, because for them their argument is that you are the profession.
Okay.
You should know when you have had enough. But then on the other side, you have to choose between seeing 35 and telling the employer I will not see anybody else in your job, because also they are going to sack you.
Yes.
So it's a real balance.
Okay.
And but I think the person who suffers is the Kenyan, because that is the person who is going to get complications, or if they are given a wrong diagnosis. That is the person who will suffer the medical errors. And that is why Kenyans, the way we are coming out to call for
Change.
we should also come out and call for these things. Can we have better health systems? Can we have the whole mix of health workers. Can
Right.
we have the adequate numbers? Not as per our standards, as per the standards of the ministry itself.
Now, she asked you something in regards to the SHA, social health.
Being locked out, yes.
Yeah. As you answer that one, maybe
Yes.
can you also let us know?
Yes.
The country is divided.
Yeah.
Actually, majority of the country is saying SHA is not working. Very small number, which is mostly government and pro-government, is saying that SHA is working.
Yes.
So as we ask about that being locked out, is it working?
Very good. And the discrimination that we are talking about, and you also talked about the contracts. The discrimination that we were talking about is that clinic officers would see Kenyans under NHIF seamlessly. Their facilities would be paid. They would be onboarded. If you are a specialist, you would do your procedures. Their clinic officers who do cesarean sections and what have you, they'll do, and the facility will be paid. In comes SHA, and then we are dropped from nowhere. And they say that only those registered by KMPDC will be onboarded on SHA.
Okay.
But that was against the law, because the same law that establishes SHA, that is the Social Health Insurance Act, the SHE Act.
Yes.
You know, the people confuse between SHE, SHA, and
yeah,
those
sure.
things. So the act is called SHE Act, Social Health Insurance Act. SHA, Social Health Authority, is a board.
Authority, yes.
Is the board established by that act, and the board now manages the three funds. So, and we had foreseen what you're saying.
Yes.
Because if you go back, we had already said this is going to happen. Because we had said, if you look at the funding model for UHC that is established under the Social Health Authority, vested under the Social Health Authority and established by the Social Health Insurance,
Right.
we have three funds. We have a primary healthcare fund. This is a fund that caters for level 3 and below to community, from the CHPs where they work, dispensary, and the health centers. Where does this money come from? From the budget, the exchequer.
Yes.
Then we have the Social Health Insurance Fund. This is the money you and I contribute, 2.75%. And this money, you cannot access it until you reach level 4.
Okay.
And then,
By level 4, you mean a level 4 facility?
level 4 facility.
Okay.
You at the health center dispensary, you will not use your money. You'll only use it level 4 and above. Then you come to the other one, Emergency Chronic and Critical Care Fund. That is also budgeted from the budget. It is not whatever you contribute. Now, what is wrong with this? You also go to the better plan, the bottom-up economic
Model.
plan, and they'll tell you that we want to implement universal health coverage using primary health care model. What does that mean? You want to do preventive, we want to do promotional, and then we want to cure diseases before they complicate. We want to get them early, and that is why the CHPs exist. They are scouts for diseases,
Yeah.
so that as it crops up, we kill it. Very good. But then you come to the other side. How do you fund it? Because that principle must be funded for it to work.
Right.
So you find that we have, I think now we budgeted 13 billion. Yeah, in this budget, I think it's 13 point something billion. That is for community to level 3. And then we also say under SHA, you must go through level 2 or level 3 for you to be referred to level 4. Simply saying, you must first use the primary health care fund, but to access the money you contribute, you must be referred from these two. So 100% of Kenyans must go through there. Remember what I said?
Yes.
Primary health care, you don't have admissions, you have outpatient.
Yes.
So 100% of Kenyans, they are going to level 2, level 3, but it has been given 13 billion. About 9% who are admitted, they are going to level 4. It has 133 billion, whatever we are contributing.
Yes.
Then you ask yourself, what are we saying? We are saying we are prioritizing primary health care,
Right.
but where, and that is where 100% of the patients are
go.
going.
So
we are giving it
have-
13 billion.
Yes.
But where 9% of the patients are going, we are
There's no
giving
money.
it 133 billion. I don't know if you're understanding me.
No, I'm getting it. So basically, you're saying where the money is needed, it is not there.
It is in the primary healthcare. Because
But where it is not needed, that is where
the money is. And that is the whole problem.
Yes.
That is why you're seeing now the capitations, you are told you can only access 2,000 for dental, and that it's not a must.
Okay.
It is if it was provided in the budget. And if somebody uses it within your family,
Right.
then you cannot use it.
let me ask you a question now.
Yeah.
Because I'm sure by the time the government came up with this whole model,
Yeah.
they must have sat somewhere. I don't think it's the president who came up with it by himself.
Yeah.
Were there no medical practitioners to explain what you're telling us right now? Wamwambie cheki mheshimiwa, wezi yakeo pesa yote kwa watu wanalala hospitali. Kuna wenye wanakuja hapa kungoloa meno, kuna wenye wanakuja hapa wako na fungal infections and other things. That is where the money is needed most. No, did no one tell him that, or what are we saying? Was he misinformed? Because sometimes I ask these questions because I would also like maybe to understand.
Very good question.
I'd like to understand so that sometimes before we throw stones at the president or even the government, we get to understand maybe it is the person or people or persons who are advising him.
Yes.
Where is the issue here?
Number one, the problem is not the president. And the same mistake we did with the SHE Act, we are going if our cabinet secretary will not take the wise action and involve the stakeholders, we are going back into the same hole with this quality of care and patient safety. And the problem is that these things are done in secrecy.
Okay.
We shouted our voices hoarse during this act, when this act was being formulated. I'm sure you saw us somewhere on the media talking about this. We did so many petitions. Whatever I'm telling you, we documented before it became law. But do you know what the CS said by then, Nakumicha? After it was passed by parliament, I remember she stood on a podium and thanked the members of parliament for passing the law without even changing a comma. And I think for me, that was the time I really felt down.
Okay.
Because now it came to my understanding that these things are no longer about better healthcare. It is about who is powerful. Am I seen as politically powerful or not?
What is the cost of primary healthcare in Kenya? You've just told us 133 billion is going to level 4 mahali tunaenda kulala in case tumezidiwa. What is the cost of hii ingine?
I may not know the actual cost,
right?
But what I know is that much of the money, because in addition that would be 133 plus 13, it's 146. Much of those billions should be in the primary health care. Why? Because it has been proven that for every shilling that you put in prevention, you save 9 in curing. Okay. What we are doing in Kenya is not prevention.
The opposite.
Yes. Well, I was looking at the budget that 2025-2026 budget, the allocations. There was the medical services, the total 105 billion. Then there is a primary health care fund, which you're talking about 13.1 billion. Yeah. There is emergency, chronic and critical illness, which was given 10 billion. Then there is a digital health authority, which is given 314.2 million. And then the supplementary budget for SHA and UHC at 12.7 billion and requested additional SHA support. So which is this digital health authority given 314.2 million? Sorry, million, not billion.
Yes, the digital health authority, you know, there is that Digital Health Act. I think we have about 4 acts. We have the SHE Act, we have the Digital Health Act, and then we have this other one that provides for the FIF that retains the money. So under the Digital Health Act, you have the Digital Health Authority. This is the digital highway that carries the health information, so that they want to integrate it so that if you're seen in Kenyatta, you can go to Kakamega Referral Hospital. They will not have to ask you about your history and whichever drugs or the conditions. They'll just be able to log in with your number or with your ID and they can be able to
The
see your history.
Oh yeah, I saw that in the SHA.
And it's also the one that is carrying the SHA system.
Okay, yeah,
Yes.
yeah.
All right.
What about this supplementary budget for the SHA, which is given 12.7 billion?
Wow, that one I may not know.
Okay.
Because-
Okay.
Peterson,
Yeah.
we've come to the end of the show, unfortunately. Time kameisha haraka sana.
Yeah.
But thank you so much
Yes.
for honoring our
I
invitation.
hope we can get another time.
Of course.
There's too
Sure.
much to
Hii
discuss.
story ndio imeanza.
Yes.
So we need to definitely sit down and have
Yeah.
this conversation. But thank you so much nonetheless for getting out of that busy schedule. I'm sure right now you're going back there and getting deep into that conversation. But we definitely need to continue that same conversation right here.
But please allow me to make an appeal.
10 seconds.
I want to appeal to the CS.
Yes.
And I want to appeal to him that he should not only reason to the people around him in the ministry, he should call the stakeholders, all of them, and listen to them. There is something that we know.
Yes.
Okay.
Thank you so much.